Thank you for the honor of giving this lecture. When asked to deliver the Mary Glover lecture, I thought back to the intentions of the lecture and to Mary herself. Who was she, and why is this talk named after her? Mary was a British trained nurse who moved to Vancouver in 1968 after working in neurosurgery at St. Bartholomew's Hospital in London, where she trained. In Vancouver, she first worked at VGH, Vancouver General, and then St. Paul's, where she became the head nurse of the neurosurgical unit. Mary had been an active member of what was CAN in those days. At that time, our monthly CAN meetings rotated between the major hospitals. Do an ed session at 6 p.m. so night shift nurses could attend before their shift, and then repeat the session at 7:30 so that the nurses working days could come. One thing I remember about attending some of these sessions when Mary was head nurse was the very high-tech equipment that they had. Mary identified as a neuroscience nurse. Her family in England regarded her that way as well, hence their donation to CAN and this lecture in her name after Mary died in a plane crash. She was only 35 years old. What exactly do I mean when I say identity as a nurse? What does identity as a neuroscience nurse mean? These are the questions I've been exploring for the past few months. And while reading and reflecting on the related literature and speaking with nursing and medical colleagues, I realized that I've been wondering about this subject for the past few years as I began to move away from full-time work that I love and trying to envision and create what retirement means for me. So a bit of a roadmap. Today I'm going to speak with you about nursing identity and then specifically identity as a neuroscience nurse. I will cover a little history about the development of neuroscience nursing in our part of the world. And finally, I hope to connect all of this to you, your work, and the work of all of us through organizations like CAN. What is identity? For hundreds of years, philosophers and social scientists have been preoccupied with answering this question, asking about both individual identity and group identity. One reason is that identity, quote, shapes individual and social behavior, end quote. One of the most influential theorists of identity comes from the work of French philosopher Foucault, who defined individual and collective identity as, quote, a social construct that is created in language. According to Foucault, historical and social processes work to actively create these identities, operating sometimes subliminally through particular kinds of knowledge to shape what assumptions people accept about themselves and about others, end quote. You will see that this thinking is still very much part of modern thinking about professional identity. Accordingly, I'm going to talk about how we create identity and the impact of having that identity. Of course, my identity isn't just about how I see myself. It includes how you see me and how I think you see me, and on and on. Most of us work in institutions of some kind, so another part of our identities is how we are perceived within those institutions. And now let me turn to nursing identity. While there's fairly limited discussion in the nursing literature about this topic, what is agreed upon is that there are multiple influences on the development of professional identity. These include the behaviors and activities of the profession, our knowledge and skills, our personal alignment with nursing's values, beliefs, and ethics. In a 2022 qualitative study looking at professional identity formation in student nurses, researchers concluded that the most powerful influences were clinical experience, role models and mentors, reflection, critical thinking, and confidence. And who cares about nursing identity anyway? Well, educators do, as it's their job to grow nurses. We know that we first begin to take on the nurse identity when we distinguish ourselves from lay people and enter our nursing education programs. And early acquisition of this identity is strongly linked to student retention in nursing programs. Other people who care about nursing identity are those in workforce planning. There have even been tools designed to measure nursing identity, based on the thesis that the more one identifies as a nurse, the greater the likelihood that he or she will remain in the profession and therefore continue in the workforce. Another group who cares about nursing identity are those involved with quality, safety, and patient outcomes. For nursing identity is seen as having a fundamental importance to the quality of healthcare and is also viewed as important as to whether and how nurses expand leadership roles and skills, again with positive implications for patient care. Ideas about professional identity and roles shape nursing services management in, for example, the contested area of optimal skill mix and nurse-patient ratios. They lead to better patient outcomes. Nursing identity has even been shown to shape the extent to which nurses support healthcare reform that might affect their own jobs. In fact, one has to conclude that overall, the nursing literature on this topic is limited. By this, I mean not only has there not been a lot of research, but the ideas span a broad range of approaches and thinking. Having described identity in general and then professional nursing identity, I want to talk about identity as a neuroscience nurse. But first, a little bit about our history. What is it that distinguishes us from other nurses? Nursing identity is just beginning to be more theorized. For example, this diagram is from a 2021 publication and depicts the 4 domains of our profession, which are currently thought to feed into nursing identity. And we'll be coming back to this slide. I was lucky enough to be involved in the early days of our practice standards development, specifically specialty group recognition and development of the neuroscience nursing blueprint and then the certification exam. Over those years, it was drilled into us through CNA that we must articulate the unique needs of neuro patients and identify the requisite knowledge and skills required of the neuro nurse that were distinct from basic RN preparation. On the basis of this experience, I suggest that what is unique to us is our body of knowledge and our long history of specialization. How long have we known that neuro patients need nurses with specialized knowledge and skills? At least as far back as when neurology and psychiatry were one and the same. Let's walk through a little bit of that history. In the late 1800s, nurses began observing neurosurgical procedures at the National Hospital in Queen Square, London, the first neurological institute. The rationale was that post-operative care would be enhanced if nurses could appreciate what had been done to patients. Dr. Horsley is credited for coming up with this idea. But in my imagination, there were some shrewd nurses making this suggestion to Dr. Horsley so very carefully that he thought it was his idea. At around the same time, nurses working with neuro patients in France were being encouraged by medical colleagues like Charcot to learn about the central nervous system. The pace of neurosurgical interventions began to pick up, and this development was instrumental in fostering neurological nursing's development. By the early 1900s, psychiatry and neurology were not yet separated, and while we now talk about psychiatry and neurology as separate fields, at that time in history, they talked about the insane, or psychiatry, and the nervous, or neurology. In Philadelphia, Dr. Charles Mills began to lecture to nurses. He said, "In no class of cases is it more important for a nurse to have good principles of action and clear notions of practice than among patients suffering from nervous or mental afflictions." The course content of these lectures became a textbook. The book was entitled "The Nursing and Care of the Nervous and the Insane." This is believed to be the first neuronursing textbook. The New York Neurological Institute was founded then in 1909, incidentally the same year that the first transsphenoidal approach for a pit tumor was used. And a year later, Superintendent of Nurses Amy Hilliard organized the first post-grad neuronursing course in North America. Papers based on these lectures were published in 1911 in the American Journal of Nursing, and these were the embryonic days of what we consider the nursing literature. 100 years ago, in 1923, neurosurgeon Dr. Dandy opened the first post-op neurosurgical unit at Johns Hopkins in Baltimore, Maryland. War contributed to the development of neuronursing because of the critical care and rehab needs of injured soldiers, and increasingly, both physicians and nurses were recognizing the need for informed nurses to care for these patients. In 1934, the Montreal Neurological Institute was founded, the mission of which was dedicated to the relief of sickness and pain and to the study of neurology. Of course, many of us link the MNI to founder Dr. Wilder Penfield, who is famous for early brain mapping and epilepsy surgery, but another physician who played a key role in the early days of the MNI was Dr. Bill Cohn, One of his many contributions was his interest in nursing care and ways to improve it, and he was very supportive of the establishment of the first Canadian postgrad course in neurological and neurosurgical nursing. So just to be clear, neuroscience nursing was seen as a key ingredient in neurosciences back in the very beginning of Canada's premier Neurosciences Center. The same year the MNI opened, they recruited nurse Eileen Flanagan as nursing supervisor and then later director of nursing. At that time, nurses taking the course were there for a minimum of 6 months and up to 24 months if they were training in OR, neurosurgical OR as well. According to Carolyn Robinson, the past director of nursing at the MNI, when speaking about these students, the most significant thing they have done is to improve the nursing care of the neurologically disabled around the world. I recently returned from Japan where I visited my friend Yasue Tsujibayashi. Yasu and I met when doing the program at the Montreal Neuro in 1980. In the first 5 years following her return to Japan, Yasue educated 34 nurses in neuronursing, all of whom went to work in various parts of Japan. Now that we've covered identity, nursing identity, and a little bit of history about neuroscience nursing, I'd like to circle back to professional identity. According to a large cross-section of American nursing academics, the concept of professionalism within the discipline of nursing is largely disparate and unclear, and other health disciplines echo similar findings. Yet, more than a decade before this conclusion, the Carnegie Foundation for the Advancement of Teaching had studied the extent to which the disciplines of law, clergy, engineering, medicine, and nursing were appropriately preparing their graduates for professional practice. Of 4 recommendations made for each profession, the one consistent directive across disciplines was the need to shift the educational focus to identity formation. Our medical colleagues had already begun to do this. Much of this work in medicine was informed by works by Doctors Sylvia and Richard Crews of McGill University. Dr. Sylvia Crews was the first woman in the history of Quebec and perhaps Canada to have been appointed to a senior administrative role in a large teaching hospital, the Royal Victoria, which was right across the street from the Montreal Neuro and connected by this bridge at that time. During 17 years as medical director, she had experiences with colleagues that made her question and explore professionalism. She was puzzled by colleagues who, quote, seemed to think they could slip on and off a code of professionalism, end quote, such as engage in unethical behavior after hours. Following her tenure as a medical director, Dr. Sylvia Crews and her husband Robert spent the next 25 years studying professionalism in medicine, how to define it, how to teach and assess it, and how to ensure that medical graduates acquire a professional identity. They published widely and were invited to speak on the topic all over the world, and they remain recognized as the leading experts on the subject. Previous works by the Doctors Crews were modified and further developed after the 2010 Carnegie Foundation report came out, and those changes are reflected in this 2019 publication. Dr. Crews, Robert Crews, because Sylvia died last year, gave me permission to reprint the following figure. According to the work by the Crewses, the most powerful influences on both personal and professional identity formation are role models and mentors, and clinical and non-clinical experience. Again, echoes from the views of French philosopher Foucault. Nursing's response and uptake to the Carnegie report took quite a lot more time, and this is a traffic jam, and any of you who've been involved in university committee work will probably find this. It looks like a little bit familiar. In September 2018, 50 nurses in leadership positions in practice, education, and regulation from both Canada and the US met at the University of Kansas for the first of 2 think tanks. Using a research-based approach, their goal was to flesh out the meaning of professional identity in nursing. The goal of the first think tank to understand the state of the science regarding professional identity in nursing and to map out a way forward to build new language and knowledge for the discipline. They reached consensus on a definition for professional identity in nursing, which was a sense of oneself and in relationship with others that is influenced by the characteristics, norms, and values of the nursing discipline, resulting in an individual thinking, acting, and feeling like a nurse. They produced the 4 domains figure, which you saw earlier, and concluded that the formation of a professional identity is influenced by these 4 domains. The next year, a second think tank took place. The focus of this gathering was on making an impact. They had self-proclaimed optimist and inspirational speaker Simon Sinek as a facilitator. His work is all about finding the why. The result was this why statement: to operationalize a clear understanding of nurses' professional identity so that their unique contributions to improve health are recognized. And a final product of this work was this visual or mind map, depicting nursing identity formation. They named this the Tree of Impact. And this essentially says the same thing as the model by the Cruises, but is more granular. So far, this talk has touched on theoretical and philosophical and historical underpinnings of professional identity formation, and some of you may find it a bit too academic for your taste. What does this mean for us personally in the day-to-day delivery of care to neuroscience patients and to our practice settings? In preparing for this talk, I had the privilege of corresponding with Dr. Joanne Hickey. I'd started the conversation by writing her to ask if I could be so bold as to run my analysis past her, and she graciously agreed. Here's my analysis. In my view, the key drivers for neuronursing identity are our long history of continuous learning through workplaces, CAN chapters in our annual meeting and scientific sessions as one set of examples, structures in place like CAN and dedicated neuro units that contribute to individual nurses having access to strong role models and a shared group identity, recognition that the required competencies go beyond general RN practice, and external endorsement like the former specialty group qualification and CNA certification, early access to new information in our workplaces, which can help decrease the time lag from bench to bedside or research to practice, participation in standards development, QI work, protocol and guideline development in our own areas. And taken together, I suggest that all of these factors drive and support practice scholarship in our settings. And what do I mean by that? Dr. Hickey reminded me every time we ask the question, how will this new knowledge be integrated into neuropatient care to improve outcomes, and then translate its relevance to neuroscience nursing practice, we are engaging in practice scholarship. And I believe we all need to appreciate that much of what we do fits under the umbrella of practice scholarship, and we should be explicit about it. The aim of practice scholarship is to improve and transform healthcare delivery and improve patient outcomes, and is directly related to the need to address and resolve specific issues within the real world of practice that are related to individual patients, organizations, and communities. And as I said, they're a critical component in shortening the research to practice gap. Dr. Hickey reminded me of the importance of tacit learning. She said, tacit learning shapes the nurse. Tacit knowledge or implicit knowledge is difficult to express, more difficult to transfer to others by means of written or verbal media, and includes personal wisdom, experience, insight, and intuition. The nurse learns this from his or her clinical practice. And this thinking will resonate with those of you familiar with Patricia Spenner's novice to expert work. Dr. Hickey said, the teachers are often patients and families, other nurses, other health professionals, culture, and societal norms. She went on to say, share one reflection that I particularly liked, but some of you may need to know what this is first, as you may be too young to recognize this tool, which was a type of desktop card index containing information meaningful to the person who created it and serving as a reference tool and memory aid. Essentially, it's a really old-fashioned database. Dr. Hickey told me, I think every nurse has a Rolodex of patients and clinical encounters that taught them something about being an effective, competent, and caring nurse. This is very powerful in molding the nurse into the best version of his or herself, professional self. I started this presentation introducing the concepts of identity, nursing identity, and factors contributing to identity formation. I hope I've convinced you that neuroscience nursing as a specialty has a long history, a unique professional identity, and that we owe it to patients and families we serve, and to our interdisciplinary team members, and to each other, to both preserve and to grow our specialty. In 2004, Marlene Reimer delivered the Mary Glover Lecture. The title of her talk was Leaving a Legacy. Marlene was very involved in planning for the CAN conference being held that year in Banff, and she sat on the scientific committee. At that time, and unlike Mary Glover, who died suddenly, Marlene had a terminal illness. She knew she had a very limited time left on the planet. Yet Marlene chose to spend a significant amount of that remaining time dedicated to her professional interests and to CAN. Why? I think it's because, like me, and I suspect like many of you, being a neuroscience nurse was a big part of Marlene's identity and of how she thought she could contribute to neuroscience nursing and to the world. Thank you.